talk about another article in Dental Update, January 2025, that has pediatrics and pedodontics and orthodontics discussed in it. The contents of this article are molar incisor hypomineralization, implications in pedodontics and orthodontics, extractions, and oral habits of the child patient, and the management of molar incisor hypomineralization, and implications for early interceptive orthodontics. First of all, let's talk about periodontic interface of the molar incisor hypomineralization. There are three stages of molar incisor hypomineralization that can occur: prenatal, perinatal, and postnatal. There are many other sources for the causes of molar incisor hypomineralization as mentioned in Pediatric Dentistry by Welbury in 5th edition and 4th edition. The related study, I would say, that to look at articles in the Dental Update and British Dental Journal articles in 2018 and 2019, and Dental Update articles in 2022 and 2021. The prenatal causes before the child was born, the prenatal causes are the administration of amoxicillin, co-amoxiclav, and ibuprofen to the mother, and the administration of progesterone to lower the risk of miscarriage. The perinatal causes are during birth, the low preterm birth weight, preterm birth, and the delayed labor causing the hypoxia. Postnatal causes are severe infections, recurrent infection, respiratory infections, and again the administration of co-amoxiclav and ibuprofen, and allergic conjunctivitis medicine olopatadine. Continuing with periodontic interface of molar incisor hypomineralization, we have MIH index of treatment need as updated by EAPD. It classifies the normal teeth as index 0 with minimal breakdown such as opacities. It is classified as index 1. In index 2 and 4 there is breakdown but no sensitivity. In index 3 there is only sensitivity but no breakdown. They are further classified according to the extent of breakdown, less than 1/3, up to 1/3, and more than up to 2/3 and more than 2/3. That's it. Here EAPD is telling us how the severity of the MIH affects the treatment options. First of all, the child has presented to us at 6 years of age and it has only mild opacity, so we are going to provide tooth mousse and facial sealants. Then if it is progressive, we are going to provide him with glass ionomer sealants, then glass ionomer restoration. But when the pulp is involved, such as reversible pulpitis, we are going to provide him with preformed metal crowns. But when there is extensive breakdown, pulp has also gone away, and there is abscess, there is an extraction, as recommended by EAPD in an article in 2023. How we are going to classify the severity of MIH by basing it on the clinical examination. It will be, the article classifies the severity of MIH by looking at the lesion in the clinical examination. If the lesions are white, then it is mild. Then progressing further, it becomes brown to yellow opacities. Then the further increase is the opacity is present on the incisal edge. Then after that, the severest form is incisal edge opacities and breakdown of the tooth. As you can see, the management according to this are commonly localized microabrasion, localized composites, and tooth mousse, amorphous calcium phosphopeptide, amorphous casein phosphopeptide, and like that. We are going to talk about the orthodontic interface. There is a new index presented in this article for the orthodontists and the persons who are interested in orthodontic aspect of MIH. We are looking at multiple aspects of the complexities of MIH, such as they have compiled it under the acronym of Morse code. M is for malocclusion. If there is class 1 malocclusion or crowding, then extraction in the upper arch or the maxilla will cause the closure of the space and the treatment of the class 2 malocclusion. and O stands for opposing contacts. After we have opting for extraction, we have to look at opposing contacts. R stands for restorability of the tooth, as we have studied as we have looked at the index of treatment need for MIH, it should be 2B or 4B. So it would be restorable. S is for look at the sevens, how much they have grown, what is their angulation, and how much they have mineralized. E is for the eights. We have to be we have some evidence of eights developing, the third molar developing on the OPG before we can opt for the extraction of first permanent molars. Deciding on the first permanent molars, we are going to look at C, the crown of the second premolar, has it reached under the bifurcation of the primary deciduous molars, primary deciduous second molars. O is the orthodontic treatment, what type of orthodontic treatment such as face mask or reverse face mask we are going to give. D is for dental symptoms such as there are pre-existing apical abscesses or sensitivity. So that has to be dealt before we are going for orthodontic treatment. E is for experience. That means that the age of patient must be so low that the child is pre-cooperative or there is a significant handicap, the child cannot cooperate. So the dental experience is significant here. Now we are going to talk about extractions. Extractions are difficult when the patient already presents to you with hypodontia. There is already decreased number of teeth and you are reducing it further by extracting the unrestorable tooth. And then if you have extracted the tooth, you will use distal chew maintainer or something like that to maintain the space so that the first permanent molars when they are erupting do not get impacted. Pre-existing periapical infections and abscesses do not let us plan thoroughly for the orthodontic treatment with the inclusion of periodontic interface. So there is an emergency urgent extraction of the offending tooth is required. The Royal College of Surgeons of England has supplied us with compensating and balancing needs of the extraction. Compensating means we are going to extract the opposing first permanent molar, or we are going to do the extraction of the same arch contralateral side first permanent molar in balancing extractions. And then we are looking at that cause malocclusions. They have termed it non-nutritive digital suckling habits. So these cause the constriction of the maxilla, proclination of upper anterior teeth, and retrognathia of the mandible. And there is another term used by them is non-carious tooth tissue loss, other than the non-carious tooth surface loss that is caused by gingivitis and abrasion-like lesions. So they have provided us with a solution of hair rake appliance or putting the dominant hand of a very small patient such as a toddler covered with some mittens or something like that, or put some bad tasting or bitter tasting unharmful substance on the offending finger the child uses for thumb suckling to manage this habit and break the habit. In pedodontics, the dental trauma is very significant cause of the presentation of a child patient to the department. So the orthodontic is significant as if a child is undergoing the orthodontic treatment, there is transient apical breakdown which has to be looked at under observation by the pedodontics departments. If the need arises, there might be a root canal treatment needed. And in dental trauma, the orthodontics are used for splinting of the periodontal trauma by using wires and orthodontic brackets. Interceptive orthodontics early on in class 2 patients, class 2 skeletal class 2 patients can reduce the incidence of trauma to the proclined incisors at the age 9 to 10. Before doing the replacement of teeth, orthodontic is often required for space closing or opening, for planning of implants and space maintenance. Thank you for listening to us. Do like and subscribe and comment to Healable Molars.